Hello, this is Professor Wheeler recording our pre-recorded lecture on anxiety disorders. So the reading for this module, Halter, chapter 15, and then in the module there's a short article on SEEDS, which is an acronym for a healthy brain from John Arden. And then the story for this module is going to be therapeutic monogamy, and that's the one that will be on the next exam. The VSEM that has anxiety disorders is Linda Waterfall. Okay, the learning objectives for this module differentiate between normal anxiety and dysfunctional anxiety, describe the various types of anxiety, obsessive-compulsive issues and related disorders, and then the symptomology associated with each. Number 3, what are the two most effective forms of therapy for clients with anxiety disorders? And why do you think they need to create an initial rise in anxiety? Number 4, approximately how much of panic disorder is caused by genetic factors? Number 5, discuss interventions relevant to the treatment of anxiety, obsessive-compulsive, and related disorders. Number 6, why would you avoid giving a benzodiazepine to a patient with a history of substance abuse? Number 7, why is it helpful for an anxious patient to talk about his or her feelings and concerns? Number 8, why is it important to medicate a severely anxious patient prior to group or individual therapy? Number 9, why is it important to especially pay attention to patients experiencing severe anxiety that also have respiratory issues? And then lastly, number 10, when performing therapeutic communication with a moderate to severely anxious patient, how do you know when their anxiety is in better control? How do you know when they're improving? All right, so definitions. Anxiety is a symptom, and it's usually a response to either internal or external stressful stimuli. It's also anxiety disorders are a category of psychiatric diagnosis in the DSM-5 TR, and it frequently coexists with other disorders. Physiology of anxiety. So anxiety activates the sympathetic nervous system, causing epinephrine to be released, and that kind of upregulates your system where it makes you breathe faster. It can make you sweat and can make you nauseous and have GI issues. And our treatment for that, the main one is SSRIs have been found to be the best. It's like the first line treatment for anxiety disorders. There was research a while back with Paxil and Zoloft being the two best SSRIs for that. I believe I read that that research hasn't really held up, that the other SSRIs are just as good. SNRIs can be used as well. Theoretically, the norepinephrine should make the person more anxious, but in practice we see that if the patient doesn't respond to an SSRI, the SNRI is helpful for anxiety disorders as well. And then we have benzodiazepines that work very quickly and wear off quickly, but those are useful in the treatment of people with anxiety because it helps them get to the next thing. Sometimes people just need the experience of going, doing what they're anxious about, and they don't need the medication the next time if they have the experience, if they've faced whatever they need to face. Then we're going to talk about the 4 levels of anxiety proposed by Hildegard Peplau. And that name will come up if you go for your BSN. She's one of our first important nursing theorists. Hildegard Peplau's 4 levels of anxiety. So the first level, mild, this is considered the level that people learn at the best. you have to have some anxiety to motivate yourself to learn. Um, it's easier and the person's more able to take things in. Your vital signs might get a little elevated or excited, but it doesn't interfere with anything, and it helps you kind of actively learn the material. Next, we have moderate anxiety, and the person can still learn with moderate anxiety, but not as well as mild anxiety. The perceptual field narrows, and there's something called selective inattention, where things that are threatening, you kind of block them out and don't see them. And that, you can imagine how that really hurts you on exams if if you have that issue. The person can refocus with direction. It's not like somebody that's further along, like we talk about, where they really can't be. You can't really refocus them. And so in this situation, you help patients get their feelings out. Um, if you have to teach them something really, example, during a discharge, you're teaching somebody how to do some kind of procedure, you want to first help them, like I said, while they still can learn, they're going to be better if you can get their anxiety down to the mild level. Our next level is severe, and this is where the person really can't learn. They're they're not really hearing and seeing things accurately. Their perception is reduced. They can't think clearly enough to solve problems, can't focus. Sympathetic nervous system, like we talked about earlier with the epinephrine, it's making your heart speed up, and you can't really concentrate. And you need to get them, calm, get them into some decreased stimuli. Sometimes with patients like this, if there's nothing that, if there's no other reason, like they're diabetic or something, we get them food or something like that to help them calm down. So panic level, so they really can't see and they can't think. There's no logic, and there's a lot of usually pacing or escape type of behaviors. And at this level, the important nursing consideration is you need to protect them from doing something impulsive that might hurt them. Sometimes people have impulsive suicide attempts when they're in a panic attack. Yeah, so it's important if somebody's in a panic attack that somebody stays with the patient. You wouldn't want to leave them alone while you go and get get an Ativan or something. You're going to want to make sure at least somebody is with the patient. It doesn't mean you shouldn't give them the Ativan. It just means that, Ativan, it'll take you 5 minutes to get out of the med room, 15 minutes for it to work, and by then the panic attack is usually over. So assuming you can get a staff person to stay with that patient, that's okay to get the Ativan because they will be anxious. It'll help with kind of recovering from the panic attack, but it's not really helpful yet. It's not. They need you to keep them safe and kind of work through it and get through it. Okay, so anxiety disorders. So our basic ones here: generalized anxiety disorder, specific phobia disorder, and specific phobia disorder, another name for it you might see somewhere is simple phobia. We have obsessive-compulsive disorder, panic disorder, and social anxiety disorder. So this is a list from the DSM of the diagnostic criteria for generalized anxiety disorder, and that's to have this disorder, it's at least 6 months that you've had these symptoms, and they have to have 3 of the following 5. So restlessness or feeling on edge, easily fatigued, difficulty concentrating, irritability, muscle tension, or sleep disturbance. Probably several of you just diagnosed yourself with a generalized anxiety disorder. That's part of being in nursing schools. Specific phobia. So this is a marked, persistent fear, and it's excessive, it's not reasonable, and it can be a specific object or situation. So people that have a fear of flying, fear of heights, injections, and you see the clown down here. I think this clown is from a horror movie. Most clowns don't look quite that scary, but there are some people that have phobia of any clown. The flying one can really limit someone's life. My mother, she had a real fear of flying. She never took an airplane in her life. And, it really made it where she didn't see the world. And so that's kind of sad. There's a famous football coach, John Madden. He became a broadcaster, and he was famous for he had a big what do you call the Madden Cruiser, kind of like a big bus that he would drive from city to city. And he did that while he was a coach. He did that while he was a broadcaster. And he kind of made it his thing, but it still probably would have made his life a lot easier had he got, faced the fear and got over this phobia. When we talk about treatment a little bit later on, one of the big obstacles is that you really do have to face whatever you're fearful of or whatever you're anxious of to get over these disorders. It's natural to want to avoid them, but you'll keep it. You'll never get over it if you avoid them. Okay, so more on specific phobia, it's persistent, lasting at least 6 months. Again, these are DSM-5-TR criteria for the diagnosis. And so exposure to the stimulus almost always provokes immediate anxiety and can make the person prone to a panic attack. The fear and anxiety is out of proportion. And, when it comes to adults, you don't want to waste your time explaining to the person with a phobia why it's irrational. That person already knows it's irrational, so you don't need to educate them about that. One of the things that people don't understand about us is we are not, we're more emotional creatures than we are rational creatures. We are capable of logic more than the rest of the animal kingdom, but we aren't so much ruled by logic as we would like to think we are. So anyway, most people that have a phobia, they know it's kind of crazy that they're that scared. You look at your person with a spider phobia, and it's like, I'm like 170 pounds. Why would I be scared of a tiny spider I have no idea what a spider weighs. Sorry, the slide advanced. Yeah, so we're much bigger than a spider, and people realize it's irrational to be that scared of a spider. But, like I said, we're not as rational as we like to think we are as human beings. Anyway, the situations avoided or endured with intense anxiety, and it interferes with your life, interferes with your routine. There's some people that go way out of their way and they can't imagine facing the phobia, but so instead of trying to talk the person out of the phobia, the better place to put your attention is to just let them see that we have therapies out there that are effective, and they don't need to live with this. Life's too short to live with a phobia. Okay, obsessive-compulsive disorder, frequently referred to as OCD. So we have something that comes up, the stimulus, then we have our obsession about it, which causes distress and anxiety, and that causes more of the obsession, which causes more distress and anxiety. So one of our ways of dealing with an obsessive thought or whatever the obsession is to create some kind of ritualized behavior that makes us feel in control. So there's a compulsive to do something, and that causes a temporary relief from the distress and anxiety, and kind of reinforces doing that behavior. And so this can get really, really locked in. So obsessions are recurrent, persistent thoughts, urges, or impulses, and at some time during the disturbance, there's something intrusive, it's unwanted, and causes the person marked anxiety. Person attempts to ignore or suppress such thoughts, urges, or images, or neutralize them with some other thought or action. And the action is, an example of that is by performing a compulsion. So the obsession is the thought that's disturbing, or the urge, or the impulse that's disturbing, and then the compulsion is what relieves that impulse. It's not something that usually is, it's not really good. It does create some temporary relief. So the compulsions are repetitive behavior. So examples of compulsions for germ people, they're people that have an obsession about germs. It's hand washing. There are other things that people do where they count in their mind, or checking. So there's people that will have an obsession that even though they know they locked the door when they left the house, that they didn't lock the door. Just as an example. And so they come back and have to check the door to make sure it's locked. And then they leave again and they get that obsession back again that maybe I didn't lock it. Maybe I thought, and so they end up, it interferes with their life, the compulsion, because they can't go to work. They're late to everything because they had to stop and go back and check and see if their door was locked. So we see that with some people have an obsession. They left their curling iron on and they're gonna burn their house down, or left the garage door open and somebody's gonna steal their belongings. Those are common ones. Sometimes with OCD, we'll see that with eating disorder patients where they get so focused on all the numbers that they may have started it to lose weight, but then they get obsessed with all the details and the calories and the counting, and there's a big OCD component in eating disorders. There's other obsessions that bother people where there's. Well, I'll just tell you about a patient. I had a teenage girl who when she saw men, she would think about. She couldn't help thinking what it would be like to have to suck their penis. And this would make her very angry. It wasn't like a sexual thought that sexually excited her. It would make her very angry and upset. And it wasn't like PTSD. It wasn't because that had ever happened. She was actually had no history of sexual abuse and anything like that. And it would make her very angry, and she had to go, punch something if that, when that got too bad. Another, just an example of a sexual one. One of my coworkers the not in psych but at the school approached me and asked her teenage son. He was looking at pornography on the internet, and he ran across um, a site where they had bestiality, where there's sex, people having sex with animals, which is actually illegal. Um, and he was very upset by that, and so but his obsession became he would get these images that popped into his head of people having sex with animals, and just like the girl I mentioned in the previous example, he would get really angry and upset, and he wouldn't be able to get that image out of his head. I forget what his compulsion was that he dealt with, but it was very disturbing to him. And so yeah, so we'll talk about the treatments later, but those are some examples I've seen in the last few years. Probably the more common, the more classic, probably OCD. We used to have a little room I would take patients to interview them in that kind of had some privacy, but it also had a big window in the door so that people knew I was safe and everything. And it had a piano, and it had a TV and a kind of scattered junk, not terrible, but it was a disorganized room a little bit. And so this girl with OCD, she had to stop my interview while she went and straightened everything. Everything had to be perfectly straightened. And it took her like 5 minutes to do this, but it was something where she absolutely had to do it. And so that was interesting. All right, so another part of compulsions, they're aimed at preventing or reducing anxiety or distress, and preventing some kind of dreaded event, and they're not connected in a realistic way with what they're designed to neutralize or prevent, and they're clearly excessive. So yeah, so I've had patients where they wash their hands so much that their hands are bleeding, actually causing them to be vulnerable to infections. Yeah, panic disorder. Frequently, people will have well, this is the criteria here. So at least one of the attacks has been followed by 1 month or more of one or more of the following. So we'll go over the criteria for this. So persistent concern about the implications of the attack. They feel like they're having a heart attack, losing control, going crazy, and they fear having these attacks because they're so scary and they're embarrassing and humiliating. They make a change in their behavior related to the attack, sometimes even avoiding exercise because it upregulates your system. When we talk about treatment, that's one of the best things to do to relieve anxiety in your body is to exercise. And then it's associated with a high risk for suicide. I list this here because in my suicide lecture, I list this, and then I sometimes write a test question where panic disorder is the answer. And that's because it feels like nobody ever remembers that. In the past, when I've had to select all that apply for risk factors for suicide, people don't usually, for some reason, panic disorder doesn't stand out. But people are very impulsive and can do very dangerous things when they're in a panic attack, including kill themselves. About 1/3 of people with panic disorder also have agoraphobia. Agoraphobia, and this is again, it's the DSM criteria. It's intense fear in response to at least 2 of the following situations: public transportation, being in open spaces, being in enclosed spaces, which is also known as claustrophobia if it was only specifically that one, being in a crowd, standing in line, being outside of the home alone. So people with agoraphobia, they tend to stay in their house for sometimes years at a time. The central feature of agoraphobia is they're terrified of situations where they can't escape, and so they're afraid they're going to have a panic attack and have something really humiliating happen to them. So they can have a just kind of a vague thought that something dreadful, something bad's going to happen. And to qualify for this disorder, it has to be going on for at least 6 months. And every time, basically every time they encounter those kind of challenges, they have the same feelings. So social anxiety disorder, it's just like it says, it's tremendous anxiety about being around other people, and especially unfamiliar people. And they're very self-conscious. They feel like they're going to be judged negatively, and they're afraid they'll do something that's really embarrassing or humiliating. The person recognizes the fear is unreasonable, and uh, like some of the other things with the obsessions, they there's no use to try to argue them out of it. You really have to help them cope with it in the ways that we'll talk about in a few slides. So the fear of the social situation, it has a negative impact on the person's life. You remember Freud's definition of mental health, the ability to love and to work. Well, if you can't be around people, you can't work, and you can't really, it's going to be very hard to meet someone. And so it definitely interferes with that. And, it's very distressful. So the causes of anxiety disorders, basically, the main cause, they think it's a genetic link, that when you admit a patient with an anxiety disorder, you almost always find that in their family history, there's someone else. They may not have had the exact same disorder, but they have a severe anxiety type of issue. So the biggest cause is probably genetic, and then there's some theories that all the if the mother is under stress when they're pregnant, there's a lot of cortisol released, and that makes the child very sensitive to stress. And then the same with infancy. And also, it can be a learned behavior. But if you see someone else freaking out just by being in the open, especially if that person is your one of your parents or an older sibling that you kind of look to for guidance, then that can be learned. So one of the biggest things you'll see with people with all of the anxiety disorders is they have low self-esteem. Um, and so those kind of go hand in hand. If you feel good about yourself, you're not so anxious. You're not so worried about everything else. And so they're very critical of themselves. They're perfectionistic. They argue with you when you try to give them a compliment. Um, they ruminate on negative possibilities. They spend a lot of time worrying about what they did wrong in the past or what's going to go wrong in the future. And they can be just generally negative. So we want to assess, their level of anxiety. Are they always severe? Are they sometimes moderate? And what are the conditions around that? What coping styles do they have? What defense mechanisms do they use? Do they avoid? Do they blame other people? Um, what are their stresses in their life besides having an anxiety disorder? their self-esteem almost assuredly would be low. And do they have any suicidal thoughts? Sometimes people are very, they want to escape these feelings. It's a very uncomfortable illness to have. And then there's a lot of, from all the anxiety, all those hormones, the cortisol and everything, they have a lot of GI problems, a lot of headaches, things like that are from stress. All right, so the reason why this is all in bold is the patient. You wouldn't do a treatment plan for somebody with this kind of disorder that is, kind of ready-made by Elsevier, like some of the ones we have at work at Herrick. The patient really needs to be an active participant, or they're not gonna they're not gonna be invested in doing anything that's part of the plan. And so what we want them to have some time when they're not so anxious, when, we want them to develop some coping strategies, maintain their role expectations. In other words, keep their job, be able to keep their relationship if it's a relationship they want to keep, and identify triggers. What are the things that set them off, especially, if they have recurrent thoughts that really kind of set them off, take them down a bad path. All right, so some of the interventions we kind of already talked about. I think the only one we haven't talked about is teaching them some skills, or refer them to community resources. I know with Kaiser, they like to do. They have educational groups that you go to. Probably they're online now. And, the groups have exercises, the self-esteem exercises, all of the, probably depends on exactly which anxiety disorder the person has. But they have, put a lot of effort into developing their outpatient program for that. All right, and then have them develop a plan. What are you going to do if you're triggered? How can you do something different than what you always do? Get them to express their feelings. We have cognitive therapy where if you remember from the first week, we talked about that, where you're really working on how you're interpreting things. And so they can do a mood log, if you remember that. Those kind of things are very helpful. And the relaxation training, they have to be at a mild level of anxiety to learn some of these things that are kind of complicated, but the deep breathing, visualization, positive things, head to toe relaxation, which is also called a body scan relaxation, where you consciously relax each part of your body. And sometimes people will, as they're going down their body, they'll tense it for 5 seconds and then let it go. That sometimes helps people. Then exercise. We mentioned that earlier, that sometimes people that have panic attacks are afraid to exercise because it their heart racing and increased breathing, it reminds them of a panic attack. But actually exercise is what they need to kind of get that energy out, and in a positive way, keep them calm that way. And then meditation can be another thing that they'll fail at. Meditation is difficult. So that's something that if they can do the breathing exercises, visualization, everything, those are the easier ones. And then meditation would be after that. And, they need to understand that it's going to take some time to get good at that. So sleep hygiene, getting enough sleep, having a support system, There's something called thought stopping, and this is more for people with the obsessive compulsive disorder, where if you have the image coming in or or the words coming in, you just kind of you can actually say it out loud if you're by yourself. You can just yell stop, and sometimes that helps. Once they get good at it, they can just think stop really hard, and that'll work. Um, and the more people use it, the better they get at it. So even if it doesn't work the first couple of times, they should still keep trying to do that. Some other things to do, restrict caffeine. Sometimes we'll see patients that, a warm liquid is kind of soothing, so they'll get in the habit of drinking coffee to calm down because the warm liquid kind of calms you, but then you're loading yourself up with caffeine, which increases anxiety. Then we have sugar. There's something called displacement anxiety, which is one of the reason why, a lot of us overeat when we're anxious. So just kind of managing that and staying especially away from sugar. And then alcohol, it has a disinhibiting and it's a depressant. So in the short run, it might help with anxiety, but it almost always has a rebound effect. And it has, some long-term bad effects that we'll talk about in a different lecture if we haven't already. And then just in general, stress management. All right, some interventions to address low self-esteem. Sometimes we'll give patients assignments to write down 5 things they like about themselves. If they really seem like they have low self-esteem, you might change that to like 3 things you like about yourself, and even down to 1 thing you like about yourself. If they're really having a hard time coming up with 3. Having their goals be realistic. When they set their goals, they're setting themselves up for failure if they're not realistic. And then trying to get them to do something in an area of their life where they feel competent and they feel in control. One of the things that I do when I'm talking to patients that I know have low self-esteem, I'll try to find out something that they do feel good at and try to get them to talk about that. It kind of sounds like it's socializing, but it's actually I'm actively raising their self-esteem. But anyway, try to get them involved in something that helps them feel good about themselves. Right, so I just have this in here to refer you to the article that's in the module, the seeds. And this is John Arden. He's a neuropsychologist, and he's done a lot of trainings in the Bay Area. He's come up with this acronym, and you can see how patients really respond. These really are what you need for self-care. You need to socially connect. You need to have some physical exercise. You have to keep your mind engaged. So, if the person's not in school or educationally oriented, they can at least, read or play online chess or something like that. And then a healthy diet that's not too high in sugar and, doesn't lead them to be obese. And then just getting enough sleep. Just kind of the basic things of wellness here. So medication, the benzos, they enhance the neurotransmitter GABA. That's not one of the ones that I had you learn earlier on, but that's that's another neurotransmitter, and it helps you calm down, keeps you calm. That's what the benzos help. They give you more GABA. Problems with that is you need more and more to get the same effect, which is tolerance, and you can get addicted. Antidepressants are the current first line of treatment. The SSRI class, some people say that if we had discovered how effective they are for anxiety disorders, that they might be called anti-anxiety meds instead of antidepressants. but we found out how good they are for depression earlier. So anyway, the SSRIs, that's the first line of treatment. That's the first thing we would try with a new patient that presents with severe anxiety. And sometimes you know all the side effects of SSRIs. If the person can't tolerate an SSRI, I have seen it SNRIs be effective. The Effexor, Zymbalta, and theoretically, you would think that wouldn't work because norepinephrine kind of increases your energy and increases your anxiety in some people. But in practice, we see that it does work. I mean, it has serotonin also and norepinephrine as the primary neurotransmitters they increase, and it does help some people. So what we want, if we do have them on benzodiazepines to help with the anxiety, we want to, once it gets under control, we want to start to reduce that, and have it where they only have it around just very rarely. So other medications for anxiety disorders, Lyrica, which is it's actually a controlled substance, but it's used for nerve pain, but it also works for anxiety. The same with Neurontin, which is the one of the meds that we use for that we can use for mood stabilization to keep people out of mania, and it's an anti-seizure med also, but it's also used off-label for anxiety. On the adolescent unit, we give it a lot of times for adolescents because the parents aren't really comfortable with benzodiazepines. Then we have the beta blocker group of cardiovascular meds, cardiac meds, and probably the one most commonly given is Enderol, but really you can use any of those, any drugs from that class. And what they do is they block the panic response. So particularly with somebody with a panic disorder, beta blockers, they'll probably take it every day as long as they don't have a low blood pressure, from that, and very effective, actually. Not really habit forming, although if you do take a beta blocker for, like over a year, sometimes when people come off of it, they'll have little runs of tachycardia, but no real serious addictive qualities to it. So then we have, as our, not really our last choice, Buspar. Like I said earlier in your psychopharmacology lecture, it's not effective for most people. It works for about 30-35% of people. But the people that it works for, it's really great because you don't have a tolerance and you don't have withdrawal. And so you can go off of it the next day. There's no problems. It's one of those meds where they're not quite sure how it works, but it does work for some people. So as far as therapy goes, we have our best methods are behavior therapy, and particularly systematic desensitization, where for an example of systematic desensitization, let's say you have a spider phobia, and what a therapist would do and what a therapist does do. I had a training in a seminar in it once. Just an example for the common kind of spider phobia that people have. It starts out where the person first teaches you relaxation, and then we'll show you like drawings, maybe you got cartoon drawings of a spider, and then once you can tolerate that, then actually photos of a spider. Once you can tolerate that, then actually having maybe a spider that's like in a container that's a non-threatening spider, nothing scary. And then moving on to scarier spiders. And the psychologist whose training I went to years ago, he said that if somebody comes in with a spider phobia, if they can give him the afternoon, like 4 hours, with systematic desensitization, he can have him come in with a full-blown specific phobia for spiders, and by the end, he can have, his big tarantulas. They'll let him walk across their chest, and so I don't. He claimed it. He seems pretty convinced, and he sounded like he knew what he's talking about. But anyway, the difference between systematic desensitization and exposure therapy, the other one, these are the two big ones, is that systematic desensitization exposes you to the stimulus that you're afraid of a little at a time, in little stages, and kind of takes care of you as it's going, relaxing you, making sure you're okay before you progress. Whereas exposure therapy, it just kind of puts it in all at once. And so exposure therapy, there's a couple of other names for it. Another name is flooding. It's the same thing. And then implosion therapy with an I, implosion therapy. Those three terms are the same thing. It's basically just exposing yourself to whatever your phobia is, or whatever your fear is, and then with the idea that you'll eventually, whatever is in your psyche that's scared of that stimulus will adjust and realize that it's not a threat, because nothing bad happened, you're okay. And so that's how exposure therapy works. We discussed thoughts stopping a few minutes ago, and then I talked about the education type of groups that they like to do at Kaiser, and those are, I've heard good things about them. One of the things about anxiety disorders, you won't see a patient at a private hospital like Herrick or like John Muir with that diagnosis as their admitting diagnosis, because it's not reimbursed by insurance. So you will sometimes see it at a county hospital, because they don't rely so much on private insurance. They get Medi-Cal, Medicare, and so they don't have to worry about that kind of thing. So anyway, it's considered that anxiety disorders are not acute enough to warrant inpatient hospitalization, and that they're generally appropriate for outpatient treatment. What you will see is that the kind of things that get them hospitalized are, if they're suicidal because of it, and that's what you would see as the primary diagnosis, either depression with anxiety that made them suicidal, or something along those lines. All right, so looking at our objectives. So the difference between normal anxiety and dysfunctional anxiety, that's probably not real difficult. Everybody has some level of anxiety, but dysfunctional anxiety really interferes with your life, interferes with your ability to make it to work, interferes with your relationships. It can be quite disabling to your life. Describe the various types of anxiety, and what we're talking about is the mild, moderate, severe panic level anxiety. Then we have obsessive-compulsive disorder, and the other disorders like agoraphobia and panic disorder and all the symptoms. The two most effective forms of therapy for patients with anxiety disorders, which I discussed a moment ago, the exposure therapy and systematic desensitization. And they both create an initial rise in anxiety, and the real reason is, as when we have kind of unreasonable, irrational fears, there has to be a way to face them. There's no real way to avoid them and cure them at the same time. So that's really why. So how much of panic disorder is caused by genetic factors? I don't think we have a specific, I don't like the way that's phrased. I should change that next time. probably, more than 80% of panic disorder and anxiety disorders in general there's a genetic factor, but it doesn't mean you can't get better. You definitely can do things for treatment. Okay, so some of the interventions relevant to the treatment of these disorders. We talked about the different kinds of therapy, the different medications. Yeah. Number 6, you don't want to give a benzodiazepine to a patient with a history of substance abuse because it can be a substance of abuse. So you don't want to get them addicted to Ativan or Klonopin or any of the other benzos. Excuse me. Why is it helpful? Sometimes patients just airing their concerns, saying everything out loud to another person, having that person hear them, that can be enough to reduce their anxiety, just that alone. Number 8, sometimes you have to, for somebody to make those initial steps to go into group therapy and individual therapy, especially if they have social anxiety type of issues. Sometimes you need to medicate them to be able to, so that they can actually participate in the therapy. As long as they understand the medication isn't the therapy, the medication just allows them to get started in the therapy. So number 9, patients with severe anxiety that also have respiratory issues. You can imagine when you have something like a panic attack, your breathing is really shallow, and it's really, if you have a respiratory problem on top of that, a person is much more likely to have a bad outcome, to have a asthma attack or bronchospasm that could even put their life in danger. So number 10, when performing a therapeutic communication with a moderate to severely anxious patient, how do you know when their anxiety is getting into better control? And I know I didn't talk about it much in the lecture here, but the way that you can tell that when you're talking to a patient that's in severe anxiety, that it's starting to come down to moderate, is that the person can focus on what you're saying. The moment that they're able to make any eye contact and make any kind of thoughtful response to what you're talking about, that your interventions are working. They're starting to get less anxious, and so that's a sign that things are doing well. All right, so I'm going to end this, and we will have some point where we'll go over this in a live situation, and let me know if you have any questions about it.